Hi and welcome back to Coding Matters. In this session we'll be talking in detail about some of the COVID-19 related codes and how they affect our documentation and alter the ultimate funding and coding of those admissions. The things that we're going to look at in this particular session will be how do we document our admission of COVID-related infections. How do we document and therefore code admissions for other reasons where COVID becomes a factor, whether it's a complication or just another factor in their admission. We'll talk briefly about how COVID infections can affect obstetric care, which is relevant to some of our colleagues outside of this particular hospital. We'll also talk about COVID vaccine reactions, which are an occasional reason for presentation and even sometimes admission. I'm excited that this particular session we're doing in partnership with the Central Adelaide Local Health Network, and so I'm going to invite Mark Sammons to join me for this particular session and add some of his experience and tips for coding and documenting COVID-related issues.
Thank you, Andrew, for inviting me. I'm Mark Sammons, just the Manager of Documentation Improvement in CALHN at the moment, and talking to you today about the COVID conditions and how we best document for data accuracy and collection, because COVID is a vital area of national disease collection that we want to capture accurately, and of course there is reimbursement potentials.
So let's go back to revising how coding interacts with documentation. When you've got a particular issue, we need to make sure it's documented through investigations and presentation related to that admission. So in particular with COVID, we can't just say they have COVID. We need to actually link that with a clinical syndrome. For example, they have pneumonia from COVID-19 infection, and documenting those particular symptoms like shortness of breath, fatigue, and deconditioning even in some instances, and even in other instances delirium. So those particular symptoms they've presented with are really important at building up the entire picture, which can then be coded accurately. And then finally we finish not only with the investigations but with the care plan, which in general with COVID is a lot of supportive care, but we now have access to a number of anti-COVID medications, and so documenting them clearly as being linked with the diagnosis is important for coding. So when we're combining COVID-19, just to state COVID-19 in itself is not very helpful, because we need to understand how is COVID-19 affecting this patient. And the most common reason that we really see would be a clinical syndrome that's likely a lower respiratory tract infection, or perhaps with Omicron more towards the upper respiratory tract infection style. But if they're hypoxic, it's probably going to be lower. So something like COVID-19 pneumonia, and then again, if you haven't watched the Respiratory Coding Matters video, you can look at how do we better describe some of the complications or severity related to that. So maybe they've got type 1 respiratory failure, which is going to be a more common complication of COVID-19 pneumonia, and that really it feeds into the severity of that condition, wouldn't you say, Mark?
Yeah, and additional to that, I'll add the acute on chronic if that is present as well. Adding those extra values or descriptions adds to the data quality.
And once they're through their acute stage, it's not uncommon for a lot of people to have ongoing effects of COVID, whether it's just in the recovery phase or whether it's a separate entity, kind of like the long COVID syndrome that seems to be emerging. Being able to document some of those things, like maybe some short-term memory issues that might be codable as delirium, or maybe they're having ongoing deconditioning or myalgia that's affecting their mobility. Just better documenting those elements will help us code accurately. So in terms of COVID-19 pneumonia in particular, we've got some examples here. Let's say that someone's 55 and they presented with COVID-19 pneumonia, so the respiratory manifestation of the disease. And along with that, we've diagnosed them with having acute kidney injury related to that pneumonia, dehydration, and then also we've picked up that there's cholangitis. And we can see here Mark's kindly provided some different alternatives of how we might code this. So if the person really presented with pneumonia being the reason they presented, shortness of breath, again coming back to those symptoms that should be clearly documented, that will come as a minor complexity pneumonia and be funded to the tune of about $4,300. However, if it was that they presented more because their abdominal pain, and it happened to be that they also in the workup found that they had a COVID-19 pneumonia, cholangitis or cholecystitis would be the principal diagnosis, and then the complicating factor of the COVID-19 sits into that secondary or complication type rate, and that's literally doubled the funding in that circumstance. Did you want to make any comments about how we order our principal diagnoses versus the complications, Mark?
Yeah, absolutely. It's very, very important, the hierarchy and the way you sequence your list of comorbidities, what is going to be principal. The coding job is to code everything that is treated, so we need evidence of treatment, and your hierarchy generally will determine what is the principal procedure and principal diagnosis, and groups in the funding model assign the final funding. So as you can see in that example, these figures are current financial year, and of course they do change from year to year. So if you are watching this video in next financial year, the 22-23 financial year, these figures will generally change, but the underlying message here is your principal diagnosis and principal procedure assignment is very critical to the final grouping and final reimbursement.
Absolutely. There's a good little disclaimer on that. Things may change.
Yes.
Please consult your coding and documentation department as necessary. So when we're documenting the level of testing with COVID-19, being very specific about which form of test the patient has received and whether we have got a confirmed positive or it's at the moment a presumptive diagnosis, which is pending testing, is really important. So I've got some examples here where you might have a COVID-19 pneumonia. There's a certain assumption there that we've done testing and that we have confirmed that it is COVID-19. But if you're watching in my other videos, you know that assumptions don't work with coding. Assumptions don't work with documentation. We need to be explicit. So even very simply writing PCR positive is going to enable that piece of data. Might not necessarily change the funding or the complexity, but it is important for our data gathering purposes, both now and that may influence funding changes in the future. Likewise, if someone presents and you think that the clinical syndrome fits with a COVID-19 pneumonia, but we have not yet had testing to confirm that, you might put one of those, you're expressing the clinical uncertainty by saying probable or suspected COVID-19 pneumonia. And then hopefully by the end of the admission, you're able to document that they have had a test that has either confirmed or excluded that diagnosis. Likewise, if someone is presenting with pneumonia that is not COVID, they're likely to get a PCR to investigate and exclude COVID. So being clear that they are a COVID PCR negative pneumonia is again not going to change the complexity and funding, but is important for the way that we're gathering our statistics for now and in the future. Lastly, a lot of procedures are being done through either PCR or rapid antigen testing to exclude that patient has complicating factors for the operation. And just including that, I think that's something we should be doing anyway, because it's just good documentation to make sure that we're abiding by the safety protocols that are in place. But including that for statistical purposes is really helpful. Well, what are the things that people don't realise about the way that they document some of these test results that do actually matter, Mark?
So generally when we document, it's probably more inferred knowledge. The more you know, the less you document. So unfortunately for statistical purposes, we want to capture the best documentation or the best data possible. So to be explicit or expand is really, really important, because that will affect your future research potential on finding the right patients for the group of interested parties that you're looking at. So, and that goes for not just PCR positive testing or things being ruled out, but in general, any condition being ruled out. The coders need to know that side of things, because there are specific rules on the suspected, likely, probable documentation versus something ruled out and something treated.
So we'd like to touch a bit on obstetric care, because obviously COVID at this point in time is very much affecting the way that pregnant patients in our community are receiving their usual and other complicated care, not particularly this particular centre, but a number of hospitals around Adelaide where we're based. So being able to document a bit more clearly, and I've given some tips there. For example, if someone is pregnant and they're not requiring delivery, but they are being admitted for a COVID syndrome, such as COVID-19 pneumonia, again, see the PCR has been documented there. You can add that by saying it's complicated pregnancy, so you're linking the fact that the care for this person is going to be a bit more tricky because of the presence of the pregnancy and the other teams and specialties that will need to be involved, and perhaps considerations around which drug therapy are used in those circumstances. Likewise, if someone is time for delivery and they're going into labour and they are admitted for a normal delivery, If they then also have COVID-19 pneumonia at that time, that's going to be a complicating factor. So they may not be presenting with pneumonia, they will be presenting because they're in labour and looking to deliver their baby in a healthy way, but in the process are also diagnosed with a COVID-19 syndrome. That needs to be documented clearly. That definitely adds to the complexity of their care ultimately as well. And then it may be that either they are a close contact or that they have an asymptomatic COVID infection, which is picked up by RAT or PCR, documenting that clearly, because even though that's not necessarily going to affect the medical outcomes, it does affect the logistical arrangements of the care that they're receiving. So being really explicit about those details is very important. Not all of these are going to affect the funding, but they do affect the way that we're providing that care and the way that we're able to measure the care we've provided for the future as well. So we've got some COVID pneumonia complexity here.
So up the top we have the asymptomatic COVID infection. So that goes to just a viral grouping and a low funding of a minor complexity in that. But if you do expand out the comorbidities or complications of that, so in the second middle part we have the actual COVID-related pneumonia, PCR positive. So minor complexity, different funding groups now in respiratory infections as opposed to viral groupings.
Makes sense.
And we have more of a reimbursement appropriate for that. And lastly, and most importantly, is the comorbidities being there documented deconditioning and acute type 1 respiratory failure. Of course, the respiratory failure or pneumonia, then having treatment being nasal high flow with the rate typically above 20 for an adult, that's a coding standard. We then code that intervention and the funding model then reimburses you for that extra resource, which is actually quite expensive. So you get appropriate reimbursement of $22,000 or thereabouts.
And a lot of the time, if we're not documenting that, we're really then being underfunded for the care we delivered, because these patients, they're going to high dependency unit or intensive care unit. Just the level of staffing required for consultants, registrars, nurses, sometimes a respiratory physio and the like there, along with the equipment and resources they're consuming, is literally taking up more of our resources. And if we're not writing it right, then we're not going to be reimbursed appropriately.
Exactly. We often see that there's a lot of work going on and treatment happening, but there's not the link between what that treatment is and what the condition is that's requiring it.
And really simply, you might not be thinking in these terms, but you're thinking the person's turned up, they're oxygen dependent. That means they're hypoxic, which means you can code them broadly within the type 1 respiratory failure complication. And then here, I didn't appreciate how much of a difference that either nasal high flow or other non-invasive ventilation modalities play in terms of increasing their complexity and their funding. So that's something that I think is, people are receiving those interventions reasonably commonly when they're being admitted, and we need to make sure we're documenting to capture that data.
The coders want to get the best data quality to reimburse you best for that time.
Something I hadn't appreciated, because I don't work with a COVID specific team, is that there are other logistical arrangements for care that are being affected by COVID. And so we are admitting patients sometimes who usually receive quite a decent amount of care or carer support to be independent living in the community. And when they become a close contact, they no longer can have that carer coming to their facility or their home. Likewise, if their carer, sometimes it's a family member or a single carer from an organisation that maybe is struggling with staffing because of COVID restrictions, they become a close contact or they develop COVID. No longer can that patient receive the care they require in the community to remain independent. I suppose we're kind of admitting them for emergency respite care, to put it very simply. So ideally, the way we document that is to document the principal reason for presentation is probably the reason that they need the care. So maybe they've got really severe heart failure or some kind of lung disease, or maybe they have an intellectual impairment or another physical disability that requires that care. That's the reason that they're requiring care in hospital, and then the COVID status needs to be documented there. They might be an asymptomatic infection. They may actually develop COVID pneumonia whilst they're an inpatient, or they may just be a close contact that turns out to be PCR negative the whole time. Documenting that very clearly is important. And then making it clear about the circumstances of losing their care arrangement and the plan of how we're going to either have an interim arrangement or restore those care arrangements in the short term needs to be very clear. So talking about COVID pneumonia in particular, sometimes the COVID status may not necessarily impact the complexity and the funding a lot, but it does make a difference in terms of the data we're collecting. So please be clear about what form of test they've received and whether it was a positive or negative result. So this is another example of someone that has had another reason for admission, and then during their admission has contracted COVID, and it could be that it's minimally symptomatic or asymptomatic, or they may develop a more significant clinical syndrome. Documenting that does have a potentially very big impact. So here's an example from within my field of haematology where someone has presented and been diagnosed and started treatment for acute myeloid leukemia, a very serious diagnosis. If that was reasonably uncomplicated, that would be in the region of $8,000. If they then contract COVID-19 pneumonia, which is PCR positive, even if they don't necessarily have a big oxygen requirement or major complexity to that, that is going to feed into the complexity of the admission, often prolonging the time in hospital or complicating their discharge planning as well. And that will lift that from minor to intermediate complexity, and it's almost doubled the funding, which is an important thing.
On the left here in the darker blue, we have status conditions for most patients. It's not just COVID, but in this instance, we're talking COVID. So the deconditioning, the immunocompromised, the malnutrition, and we get the dietetics, allied health experts in to specify the degree, being mild, moderate or severe. COPD, especially with pneumonia, the delirium, plus or minus any alcohol withdrawal, and the other complications, dysphagia and malabsorption syndrome is starting to be seen in the COVID patients nowadays in ICU. Complications that are acutely affecting COVID that we're seeing that impact the funding / complexity. The enteritis, and further specifying that to being either toxic, drug-related, or bacterial or viral. And any drug resistance, if it is bacterial and their resistance to some amoxicillin or something like that, is also helpful to document to its full complexity that we can capture. Anemia, again, acute on chronic. Is it acute blood loss anemia or chronic blood loss anemia? The type is always handy for us to further specify and get the best data quality out there. UTIs or any other infections, and adjustment disorders or psych. So this list I've gathered is outside the body system of respiratory or viral being the main grouping. So anything outside that body system is always going to add the complexity. But anything of those, they're just examples, will give you the best complexity profile for these patients and then reimbursed appropriately.
And I think it's a timely reminder that although COVID-19 is so well known for causing respiratory manifestations, it does affect other bodily systems that may not be as prominent when they first arrive, but through the assessment, hopefully we're providing holistic care whilst they're in, and we're taking into account the other systems it could affect either at the time of admission or during their admission or even following. And also the big impact that any acute illness, but particularly COVID, can have on someone's mental status, and in particular COVID-19, because of the impacts on the level of isolation from their usual community that it can affect, is, I think, at much higher risk, and we've seen that both in the community and within the hospital. So we'd like to finish on COVID vaccine reactions. This is not a very common reason to present to hospital, but with the amount of vaccination going on, there's a number of cases coming in. So we've included some examples here. So maybe someone would have an anaphylactic reaction. Just listing anaphylactic reaction is helpful, but anaphylaxis can present in so many different ways. So actually writing down that they maybe had angioedema and nausea and vomiting would be quite a classic presentation with anaphylaxis as an example, but it can affect other body systems as well. And so being clear about the way that anaphylaxis is presented is really important, and then linking it, saying it's due to the COVID vaccine, and ideally which one that is, because there's several that we have access to at the moment. Another perhaps more historical example, we hope, is the COVID vaccine AstraZeneca inducing a kind of VITT or VIPIT presentation. We have had a few of them in South Australia, and so linking them very clearly and being factual about not just that it caused thrombosis, but actually saying it caused pulmonary embolism. Need to be really specific in order to code that the most accurately. And even had a patient at some point that had a DVT, wasn't specifically from the vaccine, but the vaccine caused severe myalgia and deconditioning, and that immobility was the risk factor or triggering event for the DVT. So linking the relationship that's there, it is causative, even if it's not directly causative, it can be indirectly causing these complications, and that counts. Lastly, perhaps one of the more in the news is the Pfizer vaccine that can cause myocarditis. Of course, COVID itself has a much higher risk of causing myocarditis, particularly in younger males, but the vaccine can cause that as well. And just being very explicit, myocarditis or pericarditis, maybe listing any other complicating factors like shortness of breath or fluid retention, or having an echocardiogram and perhaps what the results were of that and how they impacted management. They're all going to feed into really good quality documentation. So that's been today's session. We've been talking about how do we admit people for COVID-related infections and their manifestations. We've talked about how COVID might complicate admissions for other reasons. We've talked briefly about obstetric care and how COVID is impacting that and how to document appropriately. And we've also talked about how to document COVID vaccine reactions. Thanks for joining me, Mark. Any parting comments?
Yeah, when documenting, the coders use the whole entire record. So it's from the ED admissions, it's the Adelaide health notes, it's the nursing notes, and it is your medical ward round where we get most of the information of the diagnoses. But communicating, especially in the Adelaide health, we've found through our audits recently that the deconditioning, muscle wasting and other gastrointestinal sort of complications of malabsorption has been really prominent or valuable in collecting data and complexity based off just that one note alone. So just a shout out to the Allied Health nurses and others that also contribute. Your work is definitely valuable to the organisation and the coders, so you don't get enough recognition, I think. No offence to the doctors out there, of course.
We
but
sometimes steal the glory, I think.
But yeah, it's good to understand that the coders read everything. It takes a good amount of time to sort of dig out and sleuth detective work, what is going on. But if you document concisely, succinctly, it makes our job a lot easier and you get the best data possible, which is what we're after really, isn't it?
Absolutely. Okay, thanks for joining me, Mark.
No worries, thank you, Andrew.
Thanks for watching.
Cheers.